Hi, my name is Glenn Rowell. I'm a clinical director here at Professional Physical Therapy, and I'm going to just give a brief talk on hip biomechanics. Essentially, the osteokinematics of the hip describe a ball and socket with 3 degrees of freedom. The loose packed position is 30 degrees of hip flexion, 30 degrees of abduction, and slight external rotation. The closed pack position is extension with slight abduction and internal rotation. Interestingly, quadruped is the position of maximal articular congruency. So this really, when somebody's in quadruped, has a super effective way of helping increase their proprioception. And I find clinically what it does oftentimes is it helps normalize tone. And I've had patients, do a squat and not get an acceptable amount of hip flexion, and then go into quadruped and rock back and forth, and then repeat the squat and have it be completely normal. So I think it has a pretty drastic effect on tone and proprioception. Femoral acetabular impingement, an FAI, is really described because of 2 different variables. One being the pincer type, which is overcoverage of the femoral head by the acetabulum, and the other is the cam type, which is an altered femoral head-neck offset, essentially an elongation of bony tissue between the femoral head and the neck. In most cases, both are present. The thoracolumbar and lumbopelvic mechanics, I think something of interest to us in treating patients with hip problems is the angle of pelvic inclination. Essentially, how much anterior pelvic tilt exists in somebody's normal posture. And what that causes if somebody is excessively anteriorly pelvic tilted is an acetabular femoral impingement. So that's a population that we would have a great impact on in altering some of the length, tension, and strength and endurance issues around their pelvis and hip. It boils down to, in one manner, overcoverage of the hip or undercoverage of the hip. Somebody who's overcovered, somebody who has this bony morphology that provides too much coverage around the hip would be somebody who complains of pain in sitting, or squatting too deep, or at end range internal rotation of the hip, or even with kicking. Somebody who is undercovered, the typical dysplastic patient, is somebody whose provocational activities include standing too long, or walking too long, or running. Another concept that I thought was interesting that was described, years ago by Sarman, and I kind of dismissed, and now I've realized how it really, it does present itself often clinically, is the concept of anterior femoral head migration, or an anterior glide of the greater trochanter, and really the femoral head in the socket that could be picked up with an active straight leg raise. And it's really the product of poor gluteal and abdominal activation. Typically, iliopsoas tests long and weak. And another term that I like to use in this case is somebody who has really lost centricity, who has lost that instant center of rotation of the femoral head and the acetabulum. That might be somebody who then into quadruped might stand up and might test more normally. The hip kinematics is such that in walking, and what this speaks to is the fact that somebody who's missing range of motion in one of these planes would have to compensate, usually from their spine. Maximum flexion in walking is 20 to 40 degrees. Extension is 5 to 20. External rotation, especially just at heel strike, is 20 to 30 degrees, and maximal internal rotation at toe off is 10 to 20 degrees. The arthrokinematics, this to me, this article by Harding validated how and why that some of our joint mobilization techniques actually work, because he showed that with a certain amount of force, there was up to 3 millimeters of movement of that femoral head in the acetabulum. So a lot of the manual therapy techniques that we're performing, he showed are really moving that, even though it's a ball and socket, are moving the femoral head a pretty big distance relatively in the acetabulum. This picture by Newman describes an activation or an underactivation potentially of rectus abdominis and some of the core musculature while somebody is doing a straight leg raise. So normal activation of your core muscles would maintain a stable pelvis, while the weight of your leg and the pull from rectus abdominis pulls on your pelvis to move it anteriorly. And timing and sequencing of muscle contraction is another interesting topic. Paul Hodges described this feed-forward mechanism, and this picture would obviously be somebody who's hamstring dominant, potentially. It looks like calf dominant also. But hip extension should require an activation of transverse abdominis and gluteals and then hamstrings. So clinically, it's always a challenge to me to watch somebody do a prone straight leg raise and try and get a sense of what the timing is of their musculature and how to get it to be more of this normal feed-forward mechanism of core stabilization and then a gluteal contraction prior to the hamstrings working as the hip extensor. This dynamic lower extremity valgus, or this kinetic collapse, seems to be just kind of like the root of all evil. You know, it's the evil behind so many of the different biomechanical, issues that we see, and then the cause of hip problems and knee problems, on and on. And of interest to me is that, oftentimes we can get a sense of what's weak and then make it strong, but it really isn't until the person adopts a new movement pattern and really puts those muscles into play that this changes. And it may not change initially, but over time, your body reprograms itself to then to move out of this faulty movement pattern. And this is an illustration of just the compensated versus an uncompensated or non-compensated Trendelenburg or gluteus medius weakness gait. And this person is compensating for his right gluteus medius. It's interesting how somebody's glute medius could start to become strong, and it really requires a large amount of strength and endurance in that glute medius to eliminate this gait pattern. It takes probably upward of a 4 or 4.5 out of 5 strength to really to do away with this compensatory gait. And this is a picture of a woman with left hip extension loss, and while she's near the toe-off portion of gait on that left leg, you can see her pelvis is rotating to the left. I call this the wink, and I think I stole this from therapist Pete Dreyevich, that term. But initially, you might think that the person's hip is tight, and tightness really describes adaptive shortening of connective tissue. And most of the patients that come in, especially the younger ones, a lot of times they exhibit maybe a positive Beighton score, or they're showing that they're flexible throughout their body. They're probably not somebody in 3 or 4 weeks who has gotten adaptive shortening, and it's more of a tonal issue than a tightness issue. So some of the tools that we have in our basket to try and decrease some of that abnormal tone might be the inhibitory influence of the mechanoreceptors, some of the manual therapy, direct techniques on some of the musculature that has too much tone, or maybe even using reciprocal inhibition to somehow turn off that abnormal tone that won't allow for hip extension and gait. Probably not somebody that we right away would start to stretch. We'd probably, turn on somebody's stretch reflex more and make that muscle sore. Another slide from Newman just exemplifies the importance of the cane on the opposite side. And it talks about body weight and total vertical force at the hip with the cane on the same side versus on the contralateral side. On the contralateral side, it's 1.5 times body weight through the hip, and on the ipsilateral side, it's 3.3 times body weight. Toe touch weight bearing versus non-weight bearing. Now I think very rarely do we see anybody with any sort of hip problem that is non-weight bearing. It's really toe touch weight bearing to unweight the leg, and it's levering action from the abductors of the femoral head into the acetabulum. So biomechanical considerations are, what is the overuse injury? The overuse injury is just something that provoked some sort of biomechanical vulnerability, and that's really our job to figure out. That's what we're uniquely qualified to detect. And then from there is to establish what is the pain-producing tissue, and then what stage of healing it's in. Thank you.